Hi, this is Andrea Kane, and I'm here with you for HIT 330 Healthcare Delivery Systems. We're on week 13, which means chapter 15 in your book. We've moved on to revenue management and reimbursement, looking at how healthcare is financed. I apologize, I've been sneezing. So hopefully that will stop. If you look at your syllabus, we are on unit objectives 9.5.1 through 9.5.11. And if you're following along in your textbook, we are on page 474. So let's dive into this. Payment for healthcare services is called reimbursement. That is a very important definition that you're going to make sure that you need to know. As well as adjudication includes paying, denying, and adjusting claims. It's that whole process. Everything from paying, dealing with the denial process, getting paid, and handling whatever is left over after that and adjusting claims. So make sure that you know these two definitions very well. Healthcare insurance, some terms that you might, or some information that you might need to be aware of. Out of pocket is when you pay for healthcare with your own funds. You may have insurance, you may not, but you choose to pay out of pocket for it. That is what that is. Healthcare insurance, the definition that they give us here is that it protects a person from paying the full cost of healthcare. And I'm going to ask you to make sure that you know that definition because, hint, hint, that will be on a quiz. Did you know that coverage, health insurance coverage for all Americans was the topic of campaigning in 1912? Yes, we as a country have been debating about health insurance for 108 years or more. In 2010, the Affordable Care Act was signed into law, and we'll be looking at that in several other classes. So you just need to know about the Affordable Care Act. There's some information in your book about it, and we'll be covering that more in the future. Revenue cycle is the process of patient financial and health information moving into, through, and out of the healthcare facility, culminating with the facility receiving payment. Please make sure you understand this. And if you're not sure what it is, take a look in your book. You may want to do an internet search, but you need to understand that that is revenue cycle. And we'll break that down into a little more detail as we go through this chapter. Management of the revenue cycle is the process of supervising the entire process, which sort of makes sense. So if revenue cycle starts in patient registration and it finishes with the facility having all of the payments received, all of the write-offs done, and all of that taking place. And so managing the revenue cycle is handling everything that goes through and touches the revenue cycle. And that includes HIM. We are in the middle of the revenue cycle. We come after registration and care is provided, and we come before the claim can be billed and reimbursement can be received. So we're right there in the smack dab middle of this through our coding efforts. And as well as documentation, improvement, management, integrity, and then sometimes we are needed with accounts receivable management, but most of the time we're handling denials. They'll sometimes kick things back to us to research as to why a denial is happening or what type of documentation is missing that needs to be provided, that type of situation. Patient registration, and this is on the bottom of page 475. There's pre-registration, which is what the process that happens prior to registration. Then there's registration itself. There's insurance verification, and sometimes they need to obtain prior authorization or prior approval for whatever the healthcare is that's going to be provided. So let's talk through really quick some of what that is. Pre-registration is oftentimes considered scheduling, where either a patient or a provider's office or a clinic will contact wherever the service is going to be provided, and they say, okay, we need this test done, or we have an order for this. And so they schedule it. A good example might be if you need an x-ray. You call radiology, or you call a pre-registration number and you speak to someone, you explain what the doctor's order is that you have, you explain who the patient is, they set you up, they look at the schedule, they set you up, they might get some billing information like your insurance information, your date of birth, some things that they can do to pre-register you in the system. And then when you actually show up on the day of the appointment, right before it, you get registered. And that's where they go through, they verify your insurance, get a copy of your insurance card, they put you into their, they bring up what they have for pre-registration in their EHR system, and they finish that registration. They provide you with a notice of privacy practices. They have you sign a consent for treatment. That's all that registration process. After that, they do insurance verification, and for instance, if you needed prior authorization to the radiology procedure that you're there for, that would have been done between pre-registration and registration, as well as insurance verification. They would have done all of that before you hit registration or shortly thereafter. It can be done before registration or after registration. It really depends on what the process flow is at that organization. So let's see, moving on here. The patient access or registration department is responsible for capturing demographic information on each patient. That's like name, date of birth, next of kin, address, phone number, social security number, insurance information. I'm trying to think of what else all goes into demographics, but it's everything that identifies the patient, and that sort of thing. The third-party payer is the insurance company that pays the claim for a patient. So make sure you understand that definition as well. Coordination of benefits, or the COB, is determining which insurance coverage is the primary, secondary, or tertiary payer. Because some people have 3 different insurances or 3 different payers that will pay their claim. Most people have 1, maybe 2, but some people have 3. And one of the things that they need to do during insurance verification is this coordination of benefits. Who pays first? For instance, I have 2 types of dental insurance. I have one through my husband and one through myself. And whenever I go to the dentist, they then have to do coordination of benefits to determine who pays first. And for me personally, it happens to be my coverage through NICC that pays first, and then my husband's coverage through his employer pays second. But they have to figure that out. In the same way, if you have 2 different kinds of eye insurance and you go to the eye doctor, they have to do that. Or if you have insurance and then you have a supplemental policy and you go to get health care, they do that as well. Moving on to documentation, coding, and charge capture. This is on page 476 in your book. All services that are provided have to be documented. I'm going to say that again. All services that are provided must be documented. If they are not documented, they did not happen. I mean, they may very well have happened, but when it comes to the healthcare and reimbursement world, if it wasn't documented, it didn't happen because you can't prove it. You can't justify it. It has to have been documented at or near the time of the event. And if there's a phrase that I hope that you, one of the phrases that you need to burn into your mind in the HIT program, it's documentation needs to occur at or near the time of the event in order to be accurate, timely, and it needs to be complete. So anyway, a little bit off a rabbit trail there. I'll come back and get off my soapbox. So all services must be documented and captured into a financial account. So not only does the patient have a clinical record, but they also have a financial record for that encounter or account for that visit. A charge description master, or a CDM, and we'll study this in other classes, that's a list that contains every service and supply the facility provides and the charge for that service. So make sure that you know this information that's on the screen. And how does this work in a paper-based world? And I will tell you that the paper-based worlds are pretty much a thing in the past. Almost everybody uses EHR now for all of this. So, but we'll play along because this is what your textbook gives you. So you've got patient check-in, you create a new charge slip, you verify payment method, verify the current insurance, and update the charge slip. You collect a copay and update the charge slip. You attach the charge slip to the patient's medical record if the record is paper. You update the charge record with symptoms and vital signs pre-physician services. This is where, for instance, oops, sorry about that. This is, for instance, where you might see the medical assistant in the office or an LPN or a nurse who is doing sort of intake. They're asking you what you think is wrong. They're documenting your symptoms and what you say you think is wrong. They're taking your vital signs and all those other things and getting you ready to see the physician. They place the charge slip. Sorry about that with my screen. It gets a little excited. The charge slip on top of the record or inside the record in a patient room bin, or they flag the room for the physician, or somehow they do that. Depends on what their process is. And then the physician comes in to see the patient. They update that charge slip with physician service codes and referrals and all that information. They place that charge slip in records in the patient room bin again, or they flag it, or they hand it off to the nurse or MA, who knows that it needs to go for charge entry. And then it goes back to the front office. They complete the patient discharge process, like when you check out at the office and they ask you, do you want a copy of your records from that, or a copy of your visit from that day, or they'll ask you if you have any other questions. That completes the patient discharge process. They do the charge entry. They enter the codes that the physician might have checked off on that charge slip. They look to see if the payer covered it. If the payer is going to cover it, then they will eventually send it off to the business office, and they'll take care of handling all the billing piece of it, verifying the coding, make sure there's proper linking, and pursue patient reimbursement. If the payer is not going to cover it, they will try and collect payment for services before the patient leaves, or they will let the patient go and then send a bill to the patient for any outstanding balances. And the same thing is with the business office. Once the business office determines, okay, the payer has reimbursed what they have agreed on, let's say 80-20, so the payer's paid their 80%, the patient owes 20%, then they bill the patient for that remaining 20%. And these steps, this is a paper-based world, but these steps are essentially replicated within the EHR as well. And so this just walks you through a couple of things we can go over. When the charges are captured, that's when the claim is created. The claim is what will go off to the payer, and the claim has the charge codes on it, the dollar amounts, the codes that are required, all that type of thing. The third-party payer will then go over the claim and determine eligibility, verify that the patient's covered, and then they'll look at medical necessity. Were the services that were provided medically necessary based on the documentation, based on the codes, based on maybe a copy of the visit, all of that information? They want to make sure that the patient is just not getting services to get services, but that they were truly warranted based on the patient's condition. Then deductible is the amount the policyholder must incur. And coinsurance is a pre-established percentage of expenses. So make sure you know deductible, coinsurance, and copayment. Please, please, please. I would say on this screen, make sure you know medical necessity, deductible, coinsurance, and copayment. That will be critical for the quiz, those terms. And this is an example of claim processing. It shows you the cost. It shows you the deductible, whether or not the patient is already paid or how much they've paid and how much they owe. Is there coinsurance? For instance, does the insurance pay 80% and the patient responsible for 20%? And then is there a copayment? sometimes with ER visits or other types of visits, a patient has to pay an out-of-pocket fee for each visit, so that's added on. And so you can figure out what the insurance is paid, what the patient's going to pay, and all of that based on all of these. And we will walk through this. You will have a class next fall called Healthcare Reimbursement, and we do these kinds of examples and walkthroughs. So get excited. You can get excited about that or not. All right, so claim processing, you're going to accept, if they accept the assignment payment that's based on the fee schedule, the provider accepts that amount as being paid in full. And your book will cover this. Let's see, we are on page 477 if you're trying to look at your book. Maybe on 478 too. But the provider usually accepts the amount that was paid as payment in full unless there's some other situation going on. But when they accept the amount paid in full, it's called accepting assignment payment. And then your explanation of benefits. Every person who is covered by insurance should have an EOB, an explanation of benefits, sent to them. I think that is a law requirement, which details how the payer paid the claim and what the insured is now responsible for that was not paid by the payer. And then remittance advice, that goes to whoever billed for the services, and the remittance advice is like an explanation of benefits, but it goes to the healthcare provider. And you need to know this. So explanation of benefits details how the payer paid the claim, and that goes to whoever was the insured. A remittance advice is just like an explanation of benefits, but it explains the process to the healthcare provider who was billing for the services, who provided the services and was billing for the services. So make sure you know that. Working accounts receivable, or AR. Accounts receivable is what is owed to the organization. So it's outstanding money that's owed to the healthcare organization or the healthcare provider. And obviously, everyone wants to keep AR as low as possible. You don't want to have a huge amount of money sitting out there that's owed and hasn't been paid. You need to keep that flowing so that as you're billing, you're also receiving, and you keep that cash flow moving so that you can pay your bills. So that's why people work AR. They're constantly checking to see what is out there that's owed to the organization. Has it been paid? If it hasn't been paid, why hasn't it been paid? And figuring it out and maybe rebilling it if it needs to, or figuring out if it needs to be written off, those types of things. And that's what this slide is about. And that's what pages, bottom of page 478, top of page 479 goes over. Healthcare insurers. There are commercial insurers, managed care insurers, and government plans. And I don't want to get into the weeds with all of this because you have a whole class on this where we go over this, and not just one class. I think there's 2 or 3 classes where we will go over this over and over and over again, and we will actually do a deep dive into commercial payers, managed care plans, and government plans. Government plans are like Medicare, Medicaid, the VA, those types of things. Commercial plans might be Aetna or Blue Cross or Wellmark or just some of the other major players. And managed care, those are your HMOs, PPOs, those types of things. And this is covered in your book starting at the bottom of page 479. Goes through what commercial insurance is. So just skim through that. Make sure that you know the definitions for anything that's in kind of that seafoam green color. At least that's what it appears to be in my book today, is seafoam green. And then page 481 gets into managed care. They talk to you about HMOs, PPOs, and point of service organizations. And then They get into government-sponsored healthcare plans at the bottom of page 42, where you talk about Medicare, Part A, Part B, and then the Advantage plans, which are sort of like a Part C, and Part D, which is for prescriptions. So just know what these are, read through them, know what they are, make sure you know what the terms in the Seafoam Green are, and if you aren't sure from the context in the book, look them up in the back to familiarize yourself with those. Medicaid is also a government program. They talk about CHIP, or Children's Health Insurance Program. TRICARE and the VA talk about military. TRICARE is active duty, service members and their family. VA is veterans, obviously. And they talk about a little bit about CHAMP VA. And then Indian Health Service, that's for American Indians and Alaskan Natives. Workers' Comp is another government plan that you need to be aware of, and that's on page 487. And that is paid. Workers' Comp is a federal fund for those who are federal workers, and then there's state workers' compensation funds. I'm not going to get too much into the weeds with those, but again, just know what the Seafoam Green terms are for your quiz. So I'm not going to cover these next couple of slides because they're really in your book. Just make sure that you understand the contents. So there's commercial insurance, there's managed care, there's government-sponsored healthcare plans listed here. And this just goes through and talks about what they are and what they're for. New trends. With the Affordable Care Act of 2010, they created this health insurance marketplace or exchange where people could go and buy health insurance, and that it was somewhat subsidized so that it wasn't quite as expensive as private insurance, but it was offered by private companies. And so that has grown over the last 10 years, but it's also contracted. In the beginning, the Affordable Care Act mandated that everyone had to have health insurance or they could be fined. And you had to, when you filed your income taxes, prove that with a particular form that was provided by whoever provided you with the insurance, like an employer or the insurance company, that type of thing. So, but then there were provisions of the Affordable Care Act that were overturned as being not legal or not necessary. And throughout all of that, the health insurance marketplaces and exchanges have really contracted down. Originally, they might have had 3 or 4 options in some areas for people. Now it's down to perhaps 1 option in an area. So I'm not here to get into the politics of that whatsoever, but there's no longer a fine for those who don't have health insurance. And the marketplace and exchange, again, that's dwindled due to a variety of reasons, not just the overturning of pieces and parts of the Affordable Care Act. But just so you're aware that it is a relatively new trend, and depending on what happens in the future politically, we may see that increase again, or we may see it go away. Who knows? Consumer-directed health plans. This is on page, let's see here, bottom of page 488. These are high deductible plans. That's really what they're more known as. Rather than consumer directed, they're more known as high deductible plans. These are where the deductible is at least $1,200 per year. And you have to pay that before it kicks in. And there are some government opportunities with FSAs and HSAs where you can set aside pre-tax money out of your paycheck to help you cover that deductible. And then hospital-acquired conditions, that's on page 49. And essentially what this did was it said in the ACA that the government wasn't going to pay if someone ended up with a hospital-acquired condition, meaning that when they went into the hospital, they didn't have it, and they acquired it while they were in the hospital, and it was preventable, that the hospital should have prevented this from happening. And what you really need to know about this is that they established this hospital-acquired conditions, or HAC, reduction program. And part of that was creating what's known as the present on admission indicator, or POA indicator. And that was the way that they were able to say whether or not it was hospital acquired. So let me give you an example of this really quick. Let's say I went into the hospital and when I came in, I was in for, I don't know, let's say congestive heart failure. Not true, but just for the fun of it, we'll say congestive heart failure. That was present on admission. That's what I came in for. That's what I was treated for, according to my history and physical report from my attending physician. They said, you have CHF, and it was present on admission. So that when they went to code it, when a coder went to code it, they used a Y, meaning it was present on admission. So on my claim, that would show the ICD-10-CM code for CHF, and then it would show the present on admission indicator of Y. Let's say I was discharged home and everything was fine. That'd be great. There were no hospital-acquired conditions that happened. But let's say instead, while I was in the hospital, well, let's see, what's a good one? Because there are so many that could happen. I'm thinking like ventilator-associated pneumonia. I'm thinking developing a stage 3 or stage 4 pressure ulcer. There's a whole list of these, and I should have them memorized, and at one time I did. It's just been a while since I've done any coding in a hospital setting. So let's say that I ended up with my CHF. They had trouble controlling it, and eventually I ended up on a ventilator, and I was only on the vent for a day. But a day or two later, I developed pneumonia, and they determined that it was due to the vent. So I ended up with ventilator-acquired pneumonia. On my claim, I still have CHF as my principal diagnosis and the POA indicator of Y, but now I have ventilator-associated pneumonia, the code for that, the ICD-10-CM code for that, and my present on admission indicator is an N. So when the hospital sends off the claim to the payer, and the third-party payers have jumped on board with this outside of the government, it goes off to be paid, and they say, wait a minute, she stayed 6 days, her length of stay was 6 days, and the cost for her stay was $40,000 more than it should have been. And look, she had this, she developed this condition that was not present on admission. So therefore, we can choose not to pay for anything that's associated with that. We can choose to pay, if this falls into a higher DRG, diagnostic related group, we can choose not to pay it. And that's where you get into hospital-acquired conditions and these present on admission indicators. All right, so then of course we have more laws. In 2015, we have MACRA. And this is a quality payment program. It focuses on value over volume. It helps to streamline some of the quality programs under MIPS. And what do you really need to know about MACRA? You will need to know lots and lots and lots about MACRA, but not here, not today. Please just know, again, the terms that are in green, seafoam green on page 49. Please also know that MACRA is designed to measure 4 areas: quality, improvement activities, promoting interoperability, and cost. Oh, that's not, they didn't put that on a slide. I wish they would have. That's on page 49. The 4 areas that MACRA was designed to measure are quality, improvement activities, promoting interoperability, and cost. Make sure you know that. And then, let's see, then they move us on to utilization management, and that's on page 490. Utilization management is looking at the medical necessity, appropriateness, and efficiency of the use of healthcare services, procedures, and facilities under the provision of the applicable health benefits plan. Prospective review is prior. Prospective is before. So anytime you think prospective, think before. Concurrent means at the same time. It's happening right now, same time. Retrospective is after. It's looking back. So prospective is looking forward, retrospective is looking back, and concurrent is at the same time. These are the three types of utilization management that are done in healthcare today. All right, so some examples of prospective review. Let's say somebody is coming in to get an elective hip replacement. A prospective review includes everything of looking at what kind of procedure is going to be performed, what kind of a joint do they think they're going to use, and what kind of rehab are they going to use afterwards, and how this is all going to work. Concurrent review is while they're going through this whole process, when somebody comes in for their hip replacement, while they're in the OR or while they're still within the hospital setting receiving services after the hip replacement, they're looking at this to make sure, okay, do we use the most appropriate hip joint in this replacement procedure? Did we use the most appropriate supplies? Is this patient in the right setting? Is the patient in the ICU or are they in a regular room? When should they be discharged? And where should they be discharged to based on their situation, their physical health, their strength, all of that. Retrospective review is, oh, the patient's already gone to wherever it is they're going to go, whether that's a skilled nursing facility or home with home health care. They're already gone, and now we're looking back and we're seeing, okay, did we do the best that we could for this patient? Were the services that provided medically necessary? Were they efficient? All of that. So that gives you an idea of how that works. Case management is a bit different than utilization management, although you will often find in hospitals or healthcare systems that utilization and case management are in the same department. And sometimes the staff will work between the two, but usually if it's a big enough organization, they will have utilization review separate from case management, even if they are under the direction of the same person. Case management is collaboration between healthcare and service providers to aid in the process of assessment, planning, facilitation, care coordination, evaluation, and advocacy to meet the comprehensive health needs of an individual or family. A good example of case management is something I experienced when I was working in North Carolina. They developed a case management program, and one of the first things they did was they identified the top 20 patients utilizing healthcare. And they assign case managers to these patients. And a case manager might have 5, 10, 15, 20 patients, depending on how much of a need there was for that case manager to spend their time with that individual or family. And that case manager would look at, and typically they're nurses, utilization review and case management are typically nurses. Not that this can't be done by HIM people, but nurses particularly are well suited to case management. Utilization review, if you get an HIM person that has a really strong knowledge of clinical care and anatomy, physiology, that sort of thing, they can do it, but they have to be really experienced and knowledgeable to be able to do that. But typically RNs are doing case management and utilization review. Anyway, case management. A case manager would come in during the day, come in the morning. They would look at their list of patients to make sure they hadn't been seen for treatment or when they were planning to have their next treatment. They might contact the individual and check on them, talk to them, ask them about their medication, ask them about their activities, ask them about their weight, ask them about all the things related to their disease process or their injury or disability or whatever it is, or mental health, and try and keep them out of the hospital. Bottom line, try and keep them at, in their house in good health so that they don't need to go out for care. So working with home health to provide them maybe with assistance in the home, different things so that you don't keep seeing these patients bounce back into the ED, bounce back into the hospital with maybe congestive heart failure exacerbation or COPD exacerbation, those types of things. So healthcare reimbursement methodologies. This is on page 491. There are several of these. There's fee-for-service, value-based purchasing, and traditional fee-for-service reimbursement, as well as managed fee-for-service reimbursement, episode of care reimbursement, capitation, global payment, prospective payment. You have all of these. So I'm going to refer you to your book to go through there. Again, make sure that you understand the definition for anything in Seafoam Green. You will have all of these in another class or 2 or 3. I promise you, we won't miss them. Make sure that when you get to CCs and MCCs, and that's under Medicare Acute Inpatient Prospective Payment System, that you spend a little bit of time here and understand these definitions. You don't have to be an expert, but you just need to read through these, make sure you have an understanding of those. So let me give you a quick example of these before I move on. A patient that comes in with that congestive heart failure exacerbation that I was talking about earlier and also has pneumonia. Pneumonia is an MCC. It's a major complication or comorbidity that is going to make their length of stay longer. It's going to utilize more resources, and you're going to have a sicker patient. It also changes the DRG, and it shifts that diagnostic related group into a higher one, which means a greater payment. Whereas a patient that comes in with that congestive heart failure exacerbation, and oh, by the way, they have an ulcer on their foot. That foot ulcer, it may be a CC, and so it's not a major complication or comorbidity, but they might have to have somebody take a look at it. It might need a little bit of treatment, but not the same level of treatment or severity of illness that would come with pneumonia. Non-CC would just be someone who comes in and all they've got is that congestive heart failure exacerbation. They don't have anything else going on with them, just that's it. So obviously a patient that has CHF and pneumonia is going to stay the longest. The person with CHF and this foot ulcer, which can be handled, which has to be dealt with in the hospital, but it can be handled at home with home health after discharge. Again, not the same level of intensity that someone with pneumonia might have with respiratory therapy treatments and all sorts of other things. And then somebody who doesn't have either one, they obviously don't have that same severity level. They're able to get in, get their treatment for their CHF exacerbation, and get home. And so you get paid the most for the MCC, the next amount for the CC, and then the least amount for a DRG with non-CC. RVS, this is all about physician payments. And you need to know that the components within RVS include the physician's work, their practice expenses, and the cost of their malpractice liability insurance. So you need to know that. There is skilled nursing PPS, there is outpatient prospective payment PPS, there's ambulatory surgery center PPS, there's home health PPS, there's an ambulance fee schedule PPS, all of these. And we will go over them in excruciating detail when next fall. In different classes that you have. So please don't worry about them here. Just make sure that you are aware that they exist. And you can do that through looking at these slides in your book. All right, so that is it for chapter 15. Next week is Thanksgiving week. I will have the lecture video posted for chapter 16. All you'll have is an online discussion and the quiz on chapter 16. And I will try and make that as easy as I possibly can so that you can enjoy the week with your family and loved ones, hopefully. Take care of yourselves and have a wonderful week, a wonderful Thanksgiving week, and I will be back to talk to you week 15 about chapters 12 and 18. And those will be our last chapters in the book. There are lots of chapters we didn't cover in the book. Those we'll either come back to in subsequent classes, or you will get that information multiple times in multiple classes. So no need to worry that you have missed anything. Take care.